Hello, and welcome back to another engaging episode of MedSynapse's medical podcast. I am your host, Dr. Harshita, and today we are honored to have the esteemed presence of Dr. Rahul Misra, a highly accomplished clinical oncologist, currently working at Kent Oncology Center in MedStem. Dr. Rahul's expertise in the field of oncology is truly remarkable, having held distinguished positions at renowned institutions like HCG Cancer Center in Vadodara and Apollo Hospital in Bilaspur. He earned his medical degree from GMK Medical College in Salem, Tamil Nadu, and pursued further specialization in radiation oncology, obtaining an MD degree from the esteemed Gujarat Cancer and Research Institute. We are immensely grateful to have Dr. Rahul join us today, sharing his wealth of knowledge and experience in the realm of oncology. Welcome, Dr. Rahul, and thank you for being here with us.
Thank you for inviting me. It's been a wonderful experience, and hope I can share some bits of information that can be useful for others. Thank you.
Thank you, Doctor. So, without any further delay, let's start the session. So, Doctor, what are the common types of head and neck cancer you encounter in your practice, and how do you approach their diagnosis and staging?
Uh, okay, so basically, head and neck cancers they are one of the most common cancers in India, and even in abroad, though they may not be that common. But because of the P16 epidemic, the human papilloma virus, we are seeing an increase in the levels of the oropharyngeal cancers. So, if you are asking me what types of cancers that we usually see, uh, we usually tend to see oropharyngeal cancers a lot. That would include cancers of the tonsil, base of tongue, vallecula. Uh, in addition to that, there are quite a lot of oral cavity cancers. I must admit that the incidence of oral cavity cancers was much more in my practice in India because of the habit of tobacco chewing that is very much common, unfortunately, in our part of the world. And the other major sites that do come across are carcinoma of the larynx and the hypopharynx. So yeah, but the most common causes for that, usually it is linked to allow. I'll have to divide it into two. I mean, if you say that maybe in UK, in the Western population and in the Indian population, in the Indian population, still the most common factor for the head and neck cancers is tobacco in whatever form, maybe tobacco chewing or maybe smoking BDs and cigarettes. Whereas in the Western world, uh, yes, you do have incidents of smoking as well, but more than that, it is mainly because of the human papilloma virus that tends to cause these cancers. And prognosis wise, if we may say, the HPV positive cancers tend to do slightly better than those who are HPV negative. And yeah.
Thank you for sharing your insights. And we all know that HNC is the seventh most common type of cancer worldwide and comprises a diverse group of tumors affecting the upper aerodigestive tract. So, understanding the diagnostic process is crucial, and your emphasis on comprehensive evaluation demonstrate the importance of thoroughness in reaching an accurate diagnosis. So, doctor, how do you tailor treatment plans for HNC patients based on tumor location and individuals' overall health status?
So basically, we have to divide the head and neck cancers into, may I say, mainly 4 to 5 subsides. One are the oral cavity cancers that are easily accessible. You can inspect them, do the diagnosis also quite easily. Then you move behind, go to the oropharynx. The oropharynx is mainly the tonsil, the base of tongue, that region. Then you go further behind, you go to the larynx, the voice box that you have. The laryngeal cancers, they tend to usually present with changes in voice and maybe difficulty in swallowing or coughing during swallowing, things like that. Then you have the other variety, that is hypopharyngeal cancers, that may be cancers of the piriform sinus and the postcricoid area. So they may present more with difficulty in swallowing, the food getting stuck, foreign body sensation, things like that. And also, I was going down through the oral cavity, but another major site, two major sites, if may I say, is something called the nasal cavity and the paranasal sinuses. The cancers of these areas, they are also pretty much common. And then we have the cancers of the nasopharynx. That is more common in a certain subset of population, more, may I say, in the northeastern population, and it's much more common in China. One of the reasons for that being the Epstein-Barr virus, that is a major causative factor for that. And yeah, that pretty much sums up about it. And if you're talking to me about how do we tailor the treatment for each of the things, so uh, as far as the treatment is concerned, you have to take into account two things. One, that how will the treatment affect the quality of life of the patient, whether the patient will be able to swallow, have food by mouth, will be able to talk after the treatment. Because if you see, actually, the face is the most important part of your body. Anytime you get up in the morning, it's the face that you see in yourself in the mirror, and the your impression that you create in front of anybody else is the way you talk, you present yourself. A lot of it is related to the face. So just telling somebody that, you know what, we are going to treat your cancer, but you'll never be able to probably speak in your life, or you'll not be able to have food by mouth ever, is not the best thing ever. In earlier days, surgery used to be the treatment of choice for all cancer. So anything, anywhere, any cancer, just take it out. But unfortunately, because of that, many patients would not be able to swallow ever in their life, not be able to speak in their life. So now the consensus is that in places where you can do a reasonable surgery, after which the patient can easily swallow things and can maintain a decent quality of life, go ahead, do surgery. That usually is for tumors of the oral cavity and also for the nasal cavity, because as you can see, they are like easily accessible areas. The surgeon can go in. They can now, with the advances in plastic surgery, surgeons are able to put free flaps and different flaps to may I say, cover the area that they have reduced or removed. Whereas if you see, go posteriorly, go behind, this entire pharynx things that I mentioned, the nasopharynx, the oropharynx, the larynx as well, and the hypopharynx, these are areas that are usually treated with non-surgical options. So what are the non-surgical options? If I may say, they mainly comprise of two major modalities, that is chemotherapy and radiation. You can sequence them in different manner. The most popular one being concurrent chemoradiation, whereby you give chemotherapy and radiation at the same time. But in cases like nasopharynx, where the tumors are more advanced, you first tend to give induction chemo, tend to downstage the tumor a little bit, shrink the tumor a little bit, and then go ahead with concurrent chemoradiation. Though in other sites, it may be a controversy. Some people may say that it has not got any survival advantage, but for logistical purposes, for improving the swallowing of the patient, it is sometimes necessary that we give the induction chemo, shrink the tumor so that the patient's swallowing improves by the time he actually starts radiation, and then you go ahead with chemo radiation. So yeah, that pretty sums it up. So basically, the anterior sites, go ahead, if possible. I have to use that word because it's not that every time you can take out a tumor. If possible, do surgery. If not, then probably you may have to give some chemo or other treatment options. And those that are behind, for them, it is usually organ preservation with chemotherapy and radiation. Yeah.
Yes, doctor. And this HNC is indeed a very complex condition, and it is essential to have a good understanding as each patient's case is unique and requires an individualized treatment strategy in managing such a diverse group of cancers. So, doctor, moving ahead, how do you approach the management of recurrent and metastatic head and neck cancers? And what treatment options are available for such patients facing these challenges?
So a good point that you have brought up. Now these are two different things. Now, in many of the cancers, the main reason why they fail is distant metastasis. They tend to metastasize in different places. That does take place in head and neck cancer. I'll not say it doesn't take place, but the more common mode of failure, or may I say, unfortunately, even death, is the loco-regional recurrence. Because as you can see, this is like a very small box fitted with a large number of things together. So for surgeons to remove things also they have limitations. They cannot remove certain structures, they can remove certain structures. So and head and neck cancers are really vicious in coming back again and again. And when they come back, they tend to invade certain critical things. They may invade an artery that may cause a blowout suddenly. They may go up in the brain. It may cause into the base of skull, cause problems there. It may present as a big local recurrence over there. So it can, that is what we all are actually more worried about, may I say. So if there is a recurrence, then we have to take it in the, again, as per the place where it is. Let's say if it is in the oral cavity, you will now find people who have had multiple surgeries 3 times, 4 times and things, because now it is possible. Because even if you are removing certain things, you can put a flap and then restructure the patient, rehabilitate the patient, so that the patient can lead a good quality of life. Uh, for other sides, I'm afraid, like, yes, in larynx, I would say that if you have a recurrence post chemo radiation, there is a good treatment option of salvage laryngectomy, meaning they'll remove your larynx and in some cases even the portion of the pharynx as well along with that, and then they'll do uh, they'll may do a gastric pull up sometimes and things like that, or else reconstruct the food pipe. But then if you do a laryngectomy per se, I'm not talking about pharyngectomy, so pull up comes later. Laryngectomy alone, that would not require a pull up or stuff. It would just basically, they'll remove your voice box and they'll do a permanent tracheostomy. So for the patient forever has to take will have to respire through this opening. So they cannot use the nose for the breathing because they'll have to block that. Because normally, why do you have the larynx? The main function is that it prevents foreign bodies to go into the air cavity, and if you remove that, you don't have a watchman there. And if you directly use that, connect that pipe to the nose, then you will also have some food particles that are coming in through your mouth going inside your lung. So that is why then that patient would need a permanent tracheostomy. And as a result of that, the patient may not be able to speak normally forever in their life. Now you have some advances, you have artificial devices with which they are able to communicate, but yeah, that is an issue. And also in cases like in oropharynx, unfortunately, now with the robots down there, they may sometimes be able to dissect things, but it is usually difficult. As far as nodal recurrences are concerned, if possible, usually the treatment of choice is surgery because they are usually resectable. Also, I must also mention that with the advances in technology, with the radiation also, it is now very much possible to give re-radiation, meaning radiate again for the second time, or very rarely maybe third time also. The important thing to take into account is how soon has the recurrence taken place. If you are having a recurrence within 6 months, I would not say any local treatment would be worth it, because the disease is bad, the biology is bad. But something that is recurring after, let's say, 2 to 3 years or maybe 4 years, there it is worth considering some local treatment, because there, yes, the disease may not be behaving that badly. We've had some patients who have had a recurrence after 10 years of the disease. So therefore, in those cases, definitely you must go and radically give some local treatment rather than dumping it into palliative. On the other hand, if the patient is having a recurrence too soon or is having distant metastasis after treatment, there one new kid on the block is something called immunotherapy. So with immunotherapy, now this is something that there's a lot of media hype about it also, and everybody wants to know. But we need to know that you cannot just give immunotherapy in every stage of cancer. Especially, I'm talking about head and neck cancer. You need to have evidence for doing anything in oncology. So the evidence right now for using immunotherapy is for this subset, whereby you have all the other local options have failed. Either that's unresectable, untreatable local regional recurrence, or there is some distant metastasis. There you can use immunotherapy. With immunotherapy, there are two major drugs that have been vindicated. One is pembrolizumab, the other one is nivolumab. Different places may have the guidelines slightly different. Uh, so in UK, the practice is that they first tend to do a PDL1 test before they go ahead with the pembrolizumab. Whereas with nivolumab, they usually tend to use it after the patient has had at least one line of chemotherapy and has failed after that. And in addition to that, for oral cavity cancers, you also have drugs like cetuximab that can be used in combination with chemotherapy and later on as maintenance. And definitely the fourth one, and the old tried and tested option of palliative chemotherapy, also remains, like drugs like cisplatin, 5-fluorouracil. These can be used for the palliative options as well. So yeah, if I may summarize it, I'll put it this way: loco-regional recurrence, if resectable, operate. If not resectable, is it possible to re-radiate the patient? Go ahead with that. Both these local therapies fail or are not possible, then they come in the same category as probably distant meds. You have to give systemic treatment. Systemic treatment in two subheadings: one chemotherapy, another one being immunotherapy. And yeah, a third one you can put it as cetuximab, the molecular therapy, as that. But cetuximab in UK, usually the thing is they usually tend to use it mainly only for oral cavity cancers, not for others. Whereas immunotherapy you can use for all the other cases. And in first line, they do a PDL1 testing. In second line, you can give nivolumab after the chemotherapy.
Yes, doctor. And these therapies are really very powerful, and they also have a potential side effects too and complications. So, how do you minimize it while maximizing the treatment efficacy?
So good that you highlighted this point. So yeah, definitely, these are not magic drugs. They have their own share of side effects. So basically, first we'll talk about immunotherapy. With immunotherapy, the thing is that it basically activates your own body's own immune system to target the cancer cells, if I may say. For that, with that happening, a lot of side effects also happen, because sometimes the immune system may be hyperactivated. It can harm any organ of your body. To name a few, it can cause immune-related hepatitis. It can cause colitis. It can affect your lungs, pneumonitis. It can even cause neuropathy, nerve damage. Uh, so almost every organ of your body can get affected with the immunotherapy. The important thing is that you have to keep the patient in constant monitoring. Usually immunotherapy is given every 2 weeks or 3 weeks, depending upon the regimen they're using. But you have to keep the patient constantly on in constant monitoring. Make sure that you don't ignore any side effects, just like simple diarrhea, constipation. These is kind of things you can give symptomatic management for them initially. And if it becomes too severe, then you may, with immunotherapy, the main drug that is used for treating these side effects are steroids, because you have to downplay the immune system, and you have to do symptomatic management as well. And in some cases, if it is too high, the toxicity like hepatitis or colitis, you may have to withhold the immunotherapy for a few days and then again restart it only if it subsides. And if it is too severe, you may have to cancel this treatment forever. The one only advantage with immunotherapy is it usually doesn't cause immune suppression. So it doesn't cause neutropenia in that matter, usually. Whereas that is the most common side effect with chemotherapy. With chemotherapy, the main important precautions that the patients we would expect to take is that they have to avoid all sorts of infection. They should not go in crowded places. They should avoid people who are actually infected, so that because they are easily prone to these infections. Probably, if I may sum up, things like we followed during COVID, the kind of guidelines we followed during COVID may not be absolutely that much, but yeah, to some extent. And the other important thing for patients taking chemotherapy is, if at all they are having fever anytime, don't ignore it. Measure it with the thermometer. If it is more than the normal body temperature, 98.4 Fahrenheit, please, please, please contact your medical team, maybe the medical oncologist or the nurses, whomsoever is the contact number. Contact them, and if you cannot, then you may well have to be worthwhile to go to the emergency, so that they can at least do your blood test and find out that yeah, your blood counts are all right, you are not neutropenic. If you are, you may require admission. So if your doctor asks you then to get admitted, don't think that he or she is just like trying to mint money or anything. It is for your own benefit, because you may not have symptoms right now, but you are prone to get very symptomatic sometime soon. So if required, that may be, and but I'm not saying every neutropenic patient needs to be admitted. Many often it can be just managed with oral antibiotics. But if they find something that is suspicious, then it's better to get admitted. Yeah.
Yes, thank you, doctor, for providing us with a thorough understanding of these technologies and treatment modalities, along with valuable insights into strategies for mitigating potential side effects and complications. My last question is, can you provide example of a successful cases where comprehensive management led to favorable outcomes for HNC patients? And how do you coordinate care through different stages of treatment and beyond?
So I'm happy you brought this point about comprehensive management. So what do I mean by comprehensive management? See, in earlier days, the treatment used to be given just by the doctor. I mean, it was just the doctor who said it, and that is it. There is no other court of authority. But nowadays, this is more so in head and neck cancer, but it is there in all other cancers as well. That's something called team management. So what does the team consists of? The team usually consists of a radiation oncologist. If I'm talking about radiation, and yeah, let's put it both. If even if chemo radiation is there, so you'll have a radiation oncologist and a medical oncologist going for it, or maybe a clinical oncologist, whichever thing. Then you also have important team members like the dietitian, the swallowing therapist. Then you may have sometimes something called a psycho-oncologist, somebody who helps you, a counselor, to be in a more milder manner, who can help you, because these patients will have a lot of issues with so many side effects being there. So to continue treatment, so that is important. The diet is very important, because with all these oral ulcers and stuff, patients may not be able to swallow the food that they need to, because of which they may have weight loss. Also, their body's immunity dies down, because of which they become prone for infection. So it becomes a vicious cycle. When there are sometimes, unfortunately, we lose patients because of that. So it is important that there is a dietitian on board. They are seeing their patients regularly, and the patients should know to follow their advice, so that they can do what is required for them. It can involve taking artificial feeds, protein powders, or artificial supplements, so that your dietary requirements are met. It can be there are certain thickeners that sometimes help you in swallowing, so that, because if your swallowing mechanism is disrupted, so you cannot maybe sometimes think have very, may I say, clear fluid. So sometimes you require something like a thickener, resource thickener kind of things, that can make your food thick, and then you can swallow. There are swallowing exercises that usually your swallowing therapist will tell you. I would advise to go ahead and follow them up. So uh, with all these things done, so that every week you are being reviewed by one of the members, like at least you may have some, maybe your doctor may not be able to review every time, some other member of his team may be reviewing it. So one medical person, one dietitian, one swallowing therapist, and a counselor, as and when maybe that may be required. But every week you should be looked on by a lot of people. And then if you are doing those reviews regularly and following the advice that is being given in them, usually you will be able to complete the treatment in a smooth manner without any major complications. So I'll tell you one of the cases that we treated. He was a young chap, had may I say, laryngeal cancer 10 years back, for vocal cord, for which he had received radiation. 10 years later, he developed a second cancer in the oropharynx, in the tonsillar region. We treated him with re-radiation, and that time he was constantly in touch with the dietitians and the swallowing therapists. Definitely, he needed counseling as well, because it was a big shock, being a young chap, second malignancy. So it was not the best thing for him, but fortunately he completed the treatment and he's fine now. So I mean, that is one example. This very thing could have landed up into a major complication had this teamwork not taken place, because the patient could have midway stopped the treatment, saying that it is too toxic, I don't want to take it. So counselor's role comes in there. Patient may have had increased weight loss, reducing his immunity. He may have landed up in neutropenia. That could have been a major problem. Or else many a times the radiation side effects could have been so severe that if he didn't have enough proper pain control, he could not have tolerated the treatment. So every input is important, and you need to consider all of them together. That is what is comprehensive. That is, you look at a person as in total. It's not just the disease. You have to make sure that that person is comfortable and is able to complete the treatment. So that is what we mean, or I mean, about comprehensive cancer management. And also one more thing is that usually now the culture is that you should have something like a multidisciplinary team approach, whereby you have all the doctors sitting, or not only doctors, you may have even the dietitians, the salt therapists, uh, all sitting together, discuss the case, and then formulate one plan of management. Because what many times happens is that patients tend to get confused. Somebody tells this thing, other one says this thing, and the logistics waste a lot of time. You have an appointment today with the surgeon, you will have an appointment 10 days later with somebody else, and then they do some other tests. So that time is money, especially in head and neck cancers. So if we all sit together, formulate one single plan, and tell that to the patient, it saves a lot of time, and psychologically that is much better for the patient to accept. So that, I feel, is definitely a good approach to go ahead with, in whichever way. Nowadays they can be done virtually. You will also have a radiologist, a pathologist, so they all discuss you, and it gives you a good platform for everybody to interact with each one of them. And many a times we may not know things about other specialty, so it helps us. It is a good learning experience for us, and definitely it is in the best interest of the patient itself.
Yes, doctor. Thank you for this successful cases exemplify the potential of comprehensive management of HNC and underscore the importance of patient-centric, coordinated approach to delivering best possible outcomes for these for those patients who are battling complex diseases like this. And thank you, doctor. We would like to express our heartfelt appreciation for your time and invaluable insights you have shared with us today on head and neck cancer. Now, that brings to the end of today's episode. We hope you found this session informative and insightful. Remember to stay connected with MedSynapse for the latest advancements and expert knowledge. Huge thank you for tuning in. I'll see you again soon. Thank you and bye-bye.